Once we've established our patient on their non-invasive ventilation, the next step is for us now to complete our EPR documentation. So the first place you're going to come to is to your adult quick view or wherever you would access recording of patient vitals. So first section that we need to kind of put in is our normal vital parameters. Particularly of note needs to be our respiratory rate and also the oxygen therapy section that they are receiving. So in the oxygen therapy section here, you can see that there is the option to select BiPAP, or equally if your patient is on CPAP therapy, then you can select the CPAP option. So for the purposes of this, I'm actually going to select BiPAP now. So once I've signed for that, other area, that we need to record in there is whether your patient is alert, whereabouts on the APPU scale they are. So for the purposes of this, I'm going to say that they are alert. So once you've completed that section of your EPR documentation, you then now need to come down to this navigation band here, the non-invasive ventilation. If you don't have that on there, then please ask somebody or the EPR team how you can actually get the non-invasive ventilation onto your navigation bands. So once I open that, you can see this is comprised of 4 separate sections, and this is the nursing observations related directly to non-invasive ventilation. So first up is the blood gas. So initial blood gas analysis for patients need to be completed through arterial blood gas sampling. So ideally one before initiation, and then according to policy it is 1 hour after a patient has been commenced onto non-invasive ventilation, we need to complete another arterial blood gas. Currently these need to be inputted manually, so you will have to input these as point of care testing does not link to EPR currently. So once you've recorded your blood gas values, the next section that we need to come down to is our prescribed settings. Now, if we refer back to the section of the video where we were setting up the non-invasive ventilation, these are the settings that the doctor has asked the patient to receive in terms of their therapy. So the oxygen that we have here, the first one is your fraction of inspired oxygen. So for the purposes of this example, I'm going to actually record that the patient is receiving 40% oxygen. Prescribed IPAP, if you remember going back for normal initiation of BiPAP therapy, according to policy, we would be starting at an IPAP pressure of 10 centimetres of water. Our prescribed EPAP setting, again, according to local policy, we would be starting at a prescribed EPAP of 4 centimetres of water. In the initial 24 hours after initiating non-invasive ventilation, we need to try and maximise continuous non-invasive ventilation for our patients. So most of the recording that you will be doing in this activity will be continuous, but as you can see, if you have patients who are on home non-invasive ventilation, it may be that they're actually only using it overnight, maybe for sleep apnea, or if you are starting to titrate and starting to wean down non-invasive ventilation, then this is also where you can actually capture whether the patient is having breaks on and off of non-invasive ventilation. But I'm going to record this as continuous. So the next section that we have now is the non-invasive ventilation observations. So if you have recorded any of these parameters in your vital signs, then they should automatically pull through for you. You may need to double click on the cell in order for that to happen. So hopefully you will have some pretty good saturation ranges. So I'm going to input here 92% for the purposes of this example. Respiratory rate, most of your patients will still be quite tachypneic while they're on non-invasive ventilation. So for the purpose of this, I'm going to put in 24. Heart rate, say, of 96. And then your blood pressure and your conscious level also need to be recorded. Next, we need to determine which mode of ventilation that we're in. So again, it is just a case of clicking whether you're currently delivering BiPAP or CPAP therapy to that patient. So with BiPAP, we need to record both our IPAP setting, this is now what the patient is actually achieving. So not what we have asked the non-invasive ventilation to deliver to the patient, but what the patient is actually receiving. So you need to go back and look onto the screen on the Trilogy to determine what the patient is actually achieving. So I'd previously set that I wanted the machine to deliver 10. Currently, my patient is struggling to achieve this. So at the moment, I'm just going to record that the patient is actually achieving 9. Next is my EPAP, my end positive expiratory pressure, and we had that set on 4 for the previous one, and we're going to say for the purpose of this that this patient is actually receiving it. Your inspired oxygen should hopefully have pulled through from your quick view or where you've been recording your vitals. If not, that is the percentage of oxygen that is being delivered currently by the ventilator. Ventilator frequency or mandatory backup breaths. These are the ones that we set. These are the mandatory breaths that we wanted the machine to deliver to the patient should the patient not be achieving any spontaneous breaths of their own. The tidal volume, this is the patient's tidal volume, the actual tidal volume that they are expiring each breath. So you will need to again look onto the interface of the Trilogy to determine, and this is recorded in mils. Next one is the estimated leak. Now, just to remind you that with the Trilogy, using the face mask that we demonstrated in the mask fitting, the Trilogy can actually tolerate up to 60 litres of estimated leak before it is unable to continue delivering therapy to you. So you may see quite large numbers there. That is okay. The machine is designed to actually tolerate that. Mask type, delivery type. The mask that we demonstrated to you earlier in the mask fitting would be a half face mask. There are full face masks, although stocks of these are very small, and currently nasal is actually only available in paediatrics. Mouth care offered. Mouth care is an exceptionally important part of the nursing care of a patient receiving non-invasive ventilation. So this needs to be offered to the patient. Short, sharp episodes off non-invasive ventilation to offer the patient sips of water or to carry out mouth care using mouth sponges is exceptionally important. So please continue to do so and then refit the face mask and continue with your therapy. Facial skin integrity checks, these are really, really important. And I'd be expecting you to do these as a minimum of 4 to 6 hourly or as frequently as you possibly can. So going back to the mask fitting, remembering that we are not trying to achieve a complete seal around the mask. There will be an expected leak. So it's not about pulling that mask as tight as possible, but still things like the bridge of the nose can still receive quite a lot of pressure damage to them. Please do not use pressure relieving aids underneath the face mask of the non-invasive ventilation. Take the face mask off, go back to your mask fitting and actually refit that mask to be able to achieve the correct mask fitting. So normal skin integrity checks there, filter changed every 24 hours. So if you recall from the initial setup, there are 2 filters that we use normally with non-invasive ventilation. One is your expiratory port filter, which is the one that is directly linked to the Trilogy machine itself. And then there is the expiratory port filter on the patient side of the oxygen delivery. If you are caring for patients who are COVID positive whilst receiving non-invasive ventilation, then please refer to local guidance around how frequently bacterial filters need to be changed. This guidance is being updated and circulated regularly in areas where non-invasive ventilation will be delivered. Tube change weekly. This is with reference to the actual oxygen tubing that we are delivering the non-invasive ventilation through, so the corrugated tubing that we set up with the Trilogy machine. So this needs to be changed weekly and is single patient use only, so please dispose of once you have finished delivering therapy to your patient. Mask size. This goes back to exactly the same as when we did the mask fitting, small, medium and large. If you're receiving a patient who already had the mask fitted, then if you look very closely on the front of the mask, you should actually be able to see an S, M or L for small, medium, large actually written onto the face mask itself. Non-invasive ventilation alarms, on and functional. So earlier on in the setup stage of this video, I talked to you about the need to currently turn off any of the volume alarms that we have, but to keep the high and low respiratory rate alarms active. So this is where we're recording that those are active. Those parameters and those alarm settings will need to be adjusted if the patient's requirements are increasing and the patient's condition is deteriorating. You may need to increase those alarm parameters. Equally, if the patient is recovering and you are starting to titrate down the support that they are receiving, then the parameters, the alarm parameters that you've set will also need to be then adjusted accordingly to what your patient is actually doing. So the final section now of your EPR documentation is actually the NIV Treatment Log. So this is a section of the documentation where we're capturing when the patient has been commenced on non-invasive ventilation and when they have been taken off non-invasive ventilation. So ideally, this would be used to determine how long the patient has had continuous non-invasive ventilation, and maybe if they are having breaks of an hour off, that we could capture how long. This will be used in determining how well the patient is tolerating the non-invasive ventilation, but also around whether we would need to escalate the support that they are receiving in terms of the IPAP and the EPAP, or whether it be that actually we need more sustained periods of time on the non-invasive ventilation in order to actually achieve better patient outcomes and start to see improvements in respiratory function. The bottom line here, the duration of NIV spell, EPR will actually calculate that for you in minutes. So this would be used as a review tool by doctors when they're reviewing treatment of non-invasive ventilation. So that completes the non-invasive ventilation specific documentation that you need to do. I would just encourage you all to, despite what your patient's news score may be, to ensure that you do increase the frequency of vital signs observations that you are recording on your patients whilst they're receiving non-invasive ventilation. This is obviously an enhanced treatment that we are offering patients, and therefore we should be keeping a much closer eye on our patients' vital parameters to be able to identify much more readily any improvements or deteriorations that may need us to alter the therapy that we're providing through non-invasive ventilation.